Good evening, everyone. I'm presenting on behalf of Medicine 2, Hot and Knobby. Presenting a 33-year-old male school van driver with complaints of fever for the past 3 days, painful facial swelling for the past 5 days, scrotal swelling for the past 3 days. He has no known comorbidities, no history of ethanol consumption or smoking, no history of any drug abuse, no history of any high-risk behavior. And as per his knowledge and his mother's knowledge, he's been immunized, but there were no records available. On examination, he arrived to our ED with this complaints with a pulse rate of 138 per minute, BP of 110 per 70, respiratory rate of 22, temperature of 106, core temperature was checked, which was 1.6.4. He was given immediate cooling, which brought 100.7. His GCS was 15 by 15. His general examination revealed no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Local examination showed a diffuse tender swelling over the right-sided parotid region. His CVS examination was normal. Respiratory examination, normal vesicular breath sounds were heard. His abdominal examination, his genital examination showed that there was a left-sided scrotal swelling with local warmth and tenderness on palpation. And on lifting, there was pain on lifting, which is called as a brain sign positive. Central nervous system, his disease was 15 by 15. There were no focal neurological deficits. So differential diagnosis at this point of time, what we considered for the parotitis or the facial swelling was mumps, influenza A virus, parainfluenza, adenovirus, Coxsackie virus, EBV, herpes simplex, and suppurative parotitis, especially because we were considering a unilateral kind of a presentation or a non-infective kind of a pathology. What we were thinking was cyanolithiasis. The epidermolysis part, we were thinking of again mumps, rubella, Coxsackie, echovirus, and also STIs like chlamydia and gonorrhea. So our investigations showed that his hemoglobin, his total counts were around 11,300. HB was 14.1. His RFT showed mild AKI, and his mumps IgG and mumps IgM titers were noted to be positive. He had mild hepatitis, which is in a resolving trend, and his CPKs were noted to be elevated. His radiologically, we had also, because he had severe tenderness, we had also got a ultrasound of his scrotum done, which showed left epidermolysis with funiculitis and right orchitis, meaning involvement of bilateral testis. So discussion wise, so his mumps titers were elevated. I just wanted to highlight on mumps. So mumps is basically a single-stranded RNA paramyxovirus. Usually it is being thought of, it was more of a children's disease, usually presents with a constellation of fever, headache, myalgia, and usually the incubation period is around 12 to 25 days, and the infectivity is between as early as 7 days of onset to 8 days after the parotitis. So diagnosis should be made not on the basis of IgG. IgG has no value on the diagnosis. It could be exposure. Neither does it actually show preventive ability of the vaccine either. Diagnosis is made based on the RT-PCR or mumps IgM panel. RT-PCR based on the buccal swab or CSF or the serum. Unfortunately, we don't do the RT-PCR. We have based our diagnosis based on the mumps IgM values. Management is it's a self-limiting disease, and symptomatic relief can be given. Prevention wise, we should give them isolation till usually 5 to 8 days after onset of the parotitis. That is still when they are infective. The Coming to the complications, most common complication that we see is the orchitis, followed by aseptic meningitis. Encephalitis is less common. Sensory neural hearing loss, pancreatitis, pneumonia, arthritis, myocardial involvement, like even around 15% patients have noticed to have non-significant ST changes, but ST changes. Thyroiditis and interstitial nephritis were less common seen complications. Coming to the mumps vaccine here, mumps vaccine is a live attenuated vaccine. In case of an outbreak, as of now, the CDC recommends vaccination of people who have been who do not know of their vaccine status, or or those who are unvaccinated should get at least 2 MMR vaccines 28 days with the gap of 28 days. If someone has been vaccinated prior, they still recommend a third dose as of now, as per CDC's 2018 recommendation. It was noted that the vaccine had more benefit when there was more time since the last vaccination. This is based on a study which was done on University in Iowa back in 2017 when there was an outbreak. They noticed that the protection was around 50 to 70 times more on those people who have been vaccinated around 13 to 15 years before. Coming to the fact that why are we now getting, what are the factors that there is a recent increase in cases of mumps in adults right now? So multiple studies were done around the globe and in different places. What I could find was, one is waning immunity, secondary vaccine failure, antigenic variation. Why antigenic variation is, it was usually thought of it to have not have much of an antigenic variation as uh, it not of much of an antigenic variation, but we've been surveillance studies have been picking some amount of antigenic variation. Then immunogenic mismatch, meaning we've been vaccinating for another strain while the endemic strain has been another strain. Then the newer things, I mean, recently the lack of immunization and duration since immunization. So IgG, unfortunately in mumps, IgG is a very poor correlate for to know about a protection status of a patient, to know whether he'll get. So a study done in Chennai by in SRM by Dr. Malayan showed low efficacy of mumps vaccine receiving patients in Chennai. In the MMR vaccine, amongst the measles, rubella, and the mumps component, they noted that people receiving, they were almost half of them had a very poor efficacy. This was based on the fact of IgG titers, but again, IgG was not a good correlator. Here, it was attributed more not because of the vaccines problem, because of vaccine handling, meaning how it was stored, how it was administered. Uh, Coming to a newer thing, there was a surveillance study done, a large surveillance study done in Canada from 2002 to 2020, amongst them where all of these patients were vaccinated. These are all highly vaccinated patients, young patients, where they noted resurgence of mumps. So they noted the fact that they were vaccinating with a genotype of A strain, while the endemic strain at that place was genotype G. The other reason which I could find was the in 2020 there is a study which was done in Pakistan which showed that there has been a huge surge in cases of mumps there, and one of the biggest attributes there was the fact that India, Japan, Afghanistan, and Pakistan had pulled off mumps from the MMR vaccine, and they were only vaccinating for measles and rubella. Second thing, the other thing it was being attributed was the surgence of COVID and people's fear towards vaccines, so them coming forward towards vaccinating themselves. Yeah. So in our patient, basically he was managed conservatively. He also concurrently with mumps, he was noted to have a heat related illness. So we had given him aggressive cooling measures. His CPK and other levels had come down. He was vaccinated as per his family. There is no yield for vaccinating someone who has been already exposed to the natural, he's already had the disease, because the disease provides much more protection than the vaccine. He is clinically improved. Initially, he was also charted on antibiotics because we were considering suppurative parotitis, and it was because it was polymicrobial, we had empirically started him on antibiotics, which was immediately stopped after the we had got a mumps titer positive. Thank you.
Ritesh, questions from the audience?
Sir, only ice packs, sir. We did not give paracetamol and ice packs, sir. Nothing else, sir. No, sir, we did not give any steroids, sir.
Yeah. Any other questions? One more suggestion is that while formulating differentials, it's not that for each of your particular organ involvement you frame differentials. What will be the differentials when someone has got both? That will be your first list, then you can think of the other ones individually. Okay. Is he at a risk of infertility?
Bilateral involvement usually comes with the risk of infertility.
How common? Thanks to Ritesh.